This is a 74-year-old male who presented with several months of left arm fatigue during activity, along with tingling and numbness in his fingertips. He has a long history of AVM, and his medical history includes hypertension, coronary artery disease as well. His past surgical history includes an open AVM resection, followed by multiple coil embolizations with ulnar stent placements. He's a former smoker and currently takes aspirin, tadalafil, benazirpyl, and magnesium oxide. On exam, he was alert-oriented and hemodynamically stable. Through his blood pressure was elevated at 175/88. His cardiac, pulmonary, and abdominal exams were unremarkable. On inspection of the left upper extremity, there was a non-tender pulsatile bulge along the forearm, and he reported tingling and numbness in his fingertips. The skin was warm and well perfused with no discoloration or cyanosis, and you can see the pulsatile bulge clearly in this photo. All his pulses were palpable, radial, ulnar, femoral, and dorsalis pedis, so he didn't have any compromised blood flow, at least on physical exam. He also had an echo done as part of his workup, and there was no systolic dysfunction and no evidence of high output cardiac failure. This was the CTA of his left upper extremity that was done back in. Here you can see the aorta with the subclavian artery pattern. As we move further down the arm, you can start to appreciate the AVM along with previous surgical clips and embolization material. Further distally, with his ulnar stent is patent, and overall there's no significant swelling or evidence of hematoma. The vessels are patent without significant stenosis, and both radial and ulnar arteries are open distally. This is the arterial duplex that he got in about 2 months before his surgery. On the color Doppler, you can see good flow throughout. There isn't a discrete mass, but there are dilated tortuous vessels consistent with vascular malformation. Looking at the waveform, it's clearly pulsatile, but with spectral broadening, which indicates turbulent blood flow, another classic feature of AVM. He also had elevated flow velocities around 220 centimeters per second in the subclavian, and 120 in the brachial artery, which supports the presence of high-flow shunting. To briefly review, our AVMs are congenital vascular anomalies resulting from abnormal connections between arteries and veins. Essentially, the capillary bed fails to form. They are rare, affecting about 1 in 100,000 people per year, and can be classified as high-flow or low-flow lesions. Complications can include mass effect, edema, ischemia from steel, high output cardiac failure, and sometimes recurrent bleeding. Treatment depends on lesion size, flow characteristics, and symptoms. Options include open surgical resection, endovascular embolization, or covered stent placement, and non-operative approaches like compression garments, spray control, and sirolimus therapy. This patient had undergone both open and endovascular interventions previously, reflecting the complexity of managing these recurrent high-flow lesions. So for this patient, we proceeded with an endovascular approach. We took him to the OR and assessed through the right femoral artery. Using a Benson wire, we advanced into the abdominal aorta and then up into the thoracic aorta. From there, we used a burn catheter to selectively catheterize the thoracic aorta and navigated into the subclavian and then the brachial artery. At that point, we exchanged for a stiff angled glide wire and performed selective angiography. On the angiogram, you can see extensive tortuous vessels. It's difficult to tell which branches are feeding the nidus or where the exact origin lies. However, there was no significant stenosis in any of the vessels, and distal flow remained patent. For the embolization, we advanced into one of the proximal feeding branches and began embolizing with onyx. We performed slow, controlled injections, constantly monitoring catheter position to make sure there was no reflux of the embolic material and that the catheter stayed in a safe, stable position. After the first injection, you can already see the reduction in AVM filling. We then selectively embolized additional feeding branches higher up in the arm. By the end of the case, the difference was clear. This was the angiogram at the start, and this was after our intervention, showing significant reduction in AVM filling. Our final run-off to the hand showed patent radial and ulnar arteries with a small filling defect in the distal palmar arch, likely related to onyx migration. It's a great example of how, without careful control during injection, distal embolization can happen. Immediately after the procedure, the patient had a palpable radial pulse, but noted some swelling and pain in the left arm, along with tingling in digits 3 through 5 when the mid-ulnar motor weakness, so he was kept overnight. By post-operative day 1, the swelling and pain had improved, the tingling had resolved, and strength had returned, and with palpable radial pulse maintained. Overall, his early postoperative recovery was excellent. Immediately after the procedure, the patient had a palpable radial pulse, but noted some swelling and pain in the left arm, along with tingling in digits 3 through 5 when the mid-ulnar motor weakness, so he was kept overnight. By post-operative day 1, the swelling and pain had improved, the tingling had resolved, and strength had returned, and with palpable radial pulse maintained. Overall, his early postoperative recovery was excellent. So to wrap up, this case highlights the complexity of managing recurrent high-flow AVMs of the upper extremity. It really underscores the importance of a multidisciplinary approach, combining surgical, endovascular, and neurological expertise to achieve both symptom relief and limb preservation.